Hello everyone, I am Vishnu Kartik studying 𝗏𝒃. Today we are going to see about spleen. It is one of the most important topic as it may be asked in 5 marks and is also important in 𝗏𝗏 aspect. Okay. In this session we are going to see about some introduction about spleen, its location and surface markings, external features, relations, blood supply, nerve supply and lymphatics, segments, development and histology and clinical correlations. Spleen is the largest lymphoid organ of the body. Its functions include filtering the worn out RBCs and microbes, manufacturing RBCs in fetal life and lymphocytes after birth, and it stores and releases red blood cells when required. Also, it provides immunity to the body by producing immunoglobulin M by plasma cells. Location and surface marking. See here, the spleen is located in the left hypochondrial region, just behind the fundus of the stomach and in between the fundus of stomach and the dome of diaphragm, that is the left dome of diaphragm. Okay. This is the location of spleen. It is located behind the mid-axillary line. See here, this is the mid-axillary line. It is located behind the mid-axillary line with its axis along the 10th rib and its superior border at the 9th rib and its inferior border at the 11th rib. So this is the location of the spleen. It is located in the left hypochondrial region between the fundus of stomach and left dome of diaphragm, in front of the ribs and behind the mid-axillary line at the with its axis on the 10th rib and superior border on 9th rib and inferior border on the 11th rib. Then we will see about the surface marking. Surface marking is done on the posterior wall of the body on the left side. We saw that the location of the spleen that will be applicable in the surface marking, as will mark spleen along the direction of the 10th rib, as it is the axis of the spleen from the mid-axillary line, and the superior border of the 9th rib and inferior border of the 11th rib. Its medial end is 5 cm away from the 10th vertebra and its lateral end is present at the mid-axillary line. Next we move on to size, dimensions and color. Usually spleen is present as a wedge-shaped structure in most of the persons, but it is varied in some persons as tetrahedral and triangular in shape, because there may be impressions which may be more deeply located, so that there may be change in the dimension and size. Also we should know about the Harris dictum of odd numbers, which are the odd numbers from 1 to 11. They say about the size and structure of the spleen, such as the length is measured in inches, weight in oz. Okay, see here, thickness is 1 inch and then breadth is 3 inch, length is 5 inch, weight is 7 oz. Then present between the 9th and 11th ribs. So thus we can remember the external features, that is the size, dimension and the color of the spleen with this Harris dictum of numbers. Next we move on to the external features. We have 2 ends, anterior and posterior, 3 borders, superior, inferior and intermediate, 2 surfaces, diagrammatic and visceral, 2 angles, anterobasal and posterobasal angles. These anterobasal and posterobasal angles are the angles located at the junction of superior border and inferior border with its anterior end and the posterior end. Let's see everything in detail with this picture. See, first we see about the ends. This is the anterior end and this is the posterior end. Anterior end is broad and is more like a border. It is directed downwards and forwards and is present on the leftmost aspect. It is related in front with the left 𝗂𝗏 flexure, which gives a impression here. Then in the posterior end, which is blunt and rounded, it is directed upward and backward and towards medial aspect, that is towards the right. It is related to the upper pole of left kidney, as the renal impression lies here. Next we see about the borders. There are three borders: superior, inferior, intermediate borders. This one is the superior border, this is the intermediate border, and this one is the inferior border. Superior border is thin and convex. It separates the visceral surface from the diaphragmatic surface. These are the two surfaces which separates it and the superior aspect. Most important thing here is the superior border presents some notches which determines its lobulated origin. We will see that in detail in embryology, that is the development of spleen. But it is helpful in the identification of the superior border, and hence it is helpful in the identification of spleen and also the anatomical position. Next, we will see about the inferior border. Inferior border separates the visceral surface from the diaphragmatic surface on the inferior aspect, and it corresponds to the lower border of the 11th rib. Intermediate border. It is rounded in nature and separates the gastric impression. This is the gastric impression from the renal impression. This lower to the intermediate border is present the renal impression. Okay, so it separates the gastric impression, renal impression on the visceral surface. This is the intermediate border. Next we move on to surfaces. There are two surfaces, diaphragmatic and visceral. This one is the diaphragmatic surface, and here it's depicted is the visceral surface. That is, we have rotated the spleen towards to right, so that it looks like here, which is the visceral surface of the spleen. First we see about the diaphragmatic surface. Diaphragmatic surface is convex and is covered by the diaphragm. It is smooth. Okay, there will not be any irregularities. There will be smooth, convex, and it is directed upward, backward, to the left, so that it lies on the near the diaphragm. Then we move on to the visceral surface. Visceral surface, they include the impressions of the visceral organs present around the spleen. Here we can see this impression, which is produced by the stomach, which is called as gastric impression, that lies between the intermediate border and the superior border, and it is the largest impression present on the spleen. The hilum of the spleen lies at the lower border of this impression. Then we move on to renal impression. Renal impression is present between the inferior border and the intermediate border. Okay, this is the renal impression. Then colic impression. Colic impression is present on the anterior end. Okay, anterior end, because it is located near the left colic flexure, which is also called a splenic flexure, as the colon, transverse colon, comes and here continues as the descending colon. So there will be a curve, that is a flexure of this colon present near the spleen. So it is called a splenic flexure or left colic flexure. So the impression here is the colic impression. Then pancreatic impression. It is present in the intermediate border, where we have the hilum, that consists of the tail of pancreas. Then we move on to the two angles, anterobasal and posterobasal angle. The anterobasal angle is present at the junction of the superior border with the anterior end. This is the anterobasal angle. And the posterobasal angle is the junction of the posterior end with the inferior border. This is the posterobasal angle. The anterobasal angle is called as the clinical angle because it is felt easily when the spleen is enlarged on palpation. So it is very, very important, which can be determined on the enlargement of spleen, that is splenomegaly. We will see that in the clinical correlation. Next we move on to the relations. Here the relations are studied as peritoneal relations and visceral relations. Peritoneal relations are the relations formed by the peritoneal folds, which include gastrosplenic, lienorenal and phrenicocholic ligaments. Visceral relations are those which are formed by the visceral structures, that is the organs present around the spleen. That is the fundus of stomach. We saw that impression, right? That impressions are formed by these visceral structures, which come under visceral relations. Fundus of spleen, anterior surface of left kidney, left colic flexure, tail of pancreas and diaphragm. These are the visceral relations. Let's see it in detail. See, these are the peritoneal relations and these are the visceral relations. Almost the spleen is covered entirely by the peritoneum except at the hilar region, that is the hilum. Hilum is the region which is present in the intermediate border from where the vessels enter and they exit spleen. So from the hilum there will be extending peritoneal folds which are formed during a development of spleen, which will discuss detailed in the development of spleen, that is embryology. So on the formation of spleen, these two ligaments are formed, that is the glenorenal ligament and the gastrosplenic ligament. Glenorenal ligament, see the name, glenorenal. They have given this name from the end of the name of spleen, that is spleen means, that is here is given as lean, okay, to the renal, that is to the kidney. So glenorenal ligament extends from the spleen to the kidney. This glenorenal ligament is very important as the splenic artery enters into the spleen through this glenorenal ligament, and it also contains the tail of the pancreas. Then another ligament found by the peritoneum is the gastrosplenic ligament, which extends from the stomach to the spleen, that is the hilum of the spleen. Okay. Here in this ligament lies the short gastric arteries that supply the stomach. Then we have 𝗵𝒂𝗂𝐽𝗍 ligament. See here, this is the 𝗵𝒂𝗂𝐽𝗍 ligament, which is also a fold of peritoneum that extends near the diaphragm to the left colic flexure, that is the splenic flexure. It is very important here because on the enlargement of spleen, it goes towards the right iliac fossa, that is towards this direction and not towards this direction. Why is it? Because this ligament prevents the posterior dislocation of the spleen, that is towards the left iliac fossa. Okay, so the spleen enlarges noticeably on the towards the right iliac fossa, which gives an important sign that spleen is enlarged. Otherwise, we do not come to know that the spleen is enlarged. So this ligament plays an important role here. Next, we move on to the visceral relations. Visceral relations are the impressions such as the gastric impression here, as we described it in the external features. So here this is gastric impression, renal impression, colic impression and the pancreatic impression. These are the visceral relations, and also on the dorsal on the dorsal aspect we have the diaphragm. So these are the relations of spleen. Next we move on to the blood supply. Always remember that when they ask to write about blood supply, you should write about both the arterial and venous drainage. Okay, so because always we commit the mistake that when they ask blood supply, we will write only about the arterial supply and forget the venous drainage. This will lose the marks. So now we are going to discuss about splenic artery and splenic vein. Artery, that is the artery supplying the spleen, is the splenic artery, which passes through the glenorenal ligament, as we saw here. See, splenic artery travels from the glenorenal ligament and divides into 4 or 5 branches to supply the spleen. One of the most important thing is it is tortuous in nature. See here, it is not in a straight line. It is curved as so much as possible. Very few arteries in the body are tortuous in course. They are tortuous in course because they have some important role there. Here the spleen, it is located on the superior aspect of the pancreas, the splenic artery. So when the stomach distends, the spleen would move on to the more to the dorsal aspect of the stomach as the stomach enlarges enormously to 2 times to 3 times its size. So when there is stomach enlargement, splenic artery should move. At that time there should not be any disturbance to the arterial supply. So this is in tortuous nature, so that the blood supply is possible even when the stomach enlarges. Also with respiration, the spleen slightly moves up and down. So for this movement also, this to do not enter the blood supply, hinder the supply of the blood to the spleen. This in the tortuous course. Okay. Then it is classified as diffuse type of spleen or compact type of spleen. It is based on the splenic artery. That is branches of the splenic artery. When the branches split yearly, okay, when the branches split yearly, and only the branches reach the spleen, which is called as diffuse type. Compact type is that when the terminal branches arise close to the hilum. See here, when the branches arise here and only the branches enter the spleen, this is called as diffuse type. When the compact type here, then the branches do not emerge still here and then emerge, which go into the spleen, which is called as compact type. This is a small type of classification. Then venous drainage. Venous drainage is given by splenic vein, which is formed at this hilum by its tributaries. Here various tributaries contributing to the formation of splenic vein. Also, one important point in splenic artery, it originates from the celiac trunk, which is one of the important branches from the aorta, and the splenic artery is the largest branch of the celiac trunk. You will learn that in arterial supply of abdomen. Venous drainage by splenic vein, and see here the splenic vein runs on behind the body of the pancreas. Okay, splenic artery runs above the superior aspect of the pancreas, while splenic vein lies behind the pancreas. This is behind the body of the pancreas. So here it is not tortuous in course. See here, splenic vein is straight, not tortuous. This is why, because the splenic vein is slightly embedded within the posterior aspect of the body of pancreas. That is, this attached firmly, so that during the movement of the spleen, it doesn't get ruptured or hindered. So the splenic vein runs back of the pancreatic body from the left to right, and behind the neck of the pancreas it forms portal vein. See here, behind the neck of the pancreas it forms portal vein by combining with the superior mesenteric vein. Okay, so this is very important point, as a portal vein is a highly important topic, because it is also a highly clinical condition which is called portal hypertension. So in portal hypertension, blood will be more in this portal vein before reaching the liver, so that there will be more pressure of the more pressure of blood in the portal vein, which causes various effects. The tributaries of the splenic vein are short gastric veins, left gastroepiploic vein, pancreatic vein, and inferior mesenteric veins. Here short gastric veins, pancreatic veins, inferior mesenteric vein, and left gastroepiploic vein. These are the tributaries of splenic vein. Next, we move on to nerve supply and lymphatics. Nerve supply, there will be only sympathetic supply to the spleen. It is by the sympathetic plexus formed by celiac plexus, it is present around the celiac trunk, that supply the blood vessels and smooth muscles of 𝗵𝗶𝒄𝗽 and capsule. We will see what is 𝗵𝗶𝒄𝗽 and the capsule in the histology of spleen. Lymphatic drainage is not well defined, because within the spleen the tissue fluid will enter into the sinusoids directly without forming any lymphatics. But lymphatics are found along the 𝗵𝗶𝒄𝗽 capsule, which are present mostly in the outer aspect and in the visceral peritoneum, which they drain into the pancreaticosplenic nodes. Next, move on to segments. Segments, so the segments are divided on the aspect of the presence of arterial supply. That is, splenic artery divides into two branches, superior and inferior branch. Okay, so superior branch supplies this segment, superior segment. Inferior branch supplies this segment, that is inferior segment. they do not anastomose. So when there is any defect in one part, that part is affected, that is either superior or inferior segment is affected. Okay, and also there is since there is no anastomosis, there will be a zone of avascular region, that is there will be no blood supply in this zone. That is the junction between these two segments. So when the rupture of spleen, the part of spleen that has been ruptured should be removed. In order to preserve some part of spleen, which segment has ruptured, that segment only is removed. Incision is given along this line to prevent the bleeding. Okay, so it is very important to know about these segments of spleen. Also, splenic artery is segmental in origin, but splenic veins are intersegmental, that is lies between these two segments. Next we move on to the development of spleen. It is very important topic, but it should be understood so that it will be very easy. Spleen develops between the two layers of upper part of dorsal mesogastrium from the condensation of mesenchymal cells. See here, this is the stomach, primitive stomach, and this is the ventral aspect, this is the dorsal aspect. Ventral aspect is peritoneum in the ventral aspect is called as ventral mesogastrium, while peritoneum, the dorsal aspect, is called dorsal mesogastrium. So we should know that spleen arises from the dorsal mesogastrium, that is here. See, this dorsal mesogastrium forms foldings, gives folds between which forms the spleen. From the dorsal mesogastrium, between its two layers, and it's formed by the mesenchyme, that is the cells present in the dorsal mesochondrium, mesenchymal cells. These mesenchymal cells gives origin to that of the spleen. Right here, this spleen is not developed from as a single organ. First, it develops as many lobules, that is many small lobules are formed, which then unite to form the spleen. See here, there is a foldings on the dorsal mesogastrium forms the spleen here, and the spleens are formed as many small segments, that is very small lobules, which are called as spleenomegaly. Okay, the spleenomegaly fuse together before birth to form the spleen. When they doesn't fuse, there will be accessory spleens, that is additional spleens that are present between this region, that is between this folding, where we found the dorsal, where we can see the splenorenal ligament, that is glenorenal ligament, and the gastrosplenic ligament. So within these regions, we can see the accessory spleens when these lobules are not fused. The fusion of these lobules indicate that the superior border of the spleen, where we can see the notches, these notches represent the joining of the lobules of the spleen. Okay, so this is the development of spleen. So I have covered all the points here. Then we move on to the histology of spleen. Spleen is covered by a capsule. First we move from the outer aspect to the inner aspect. So on the outer aspect, spleen is covered with the capsule, which is called a splenic capsule, which sends 𝗵𝒄𝗄𝗃 inside. There is the capsule sends 𝗵𝒄𝗄𝗃 into the substance of the spleen, so that the interior is somewhat divided. Okay, see here, this is the capsule of spleen, seen the histological aspect here. This is the spleen capsule. Spleen consists of red pulp and white pulp. It is named as such because red pulp consists of blood cells and white pulp does not consist of RBCs. That is, they appear slightly, that is not red in color, which is called as white pulp. So mainly the white pulp consists of lymphoid follicles with germinal center with eccentric central nucleus. See here, this is the lymphoid follicle. See, we have marked here. This is the white pulp, which consists of lymphoid follicles, and the center we can see the germinal center, which is somewhat darkly marked. Okay, this is the germinal center, and we can see the eccentric central artery. See here, this is the central artery that is present on that is the splenic artery, which gives its branches go into the white pulp as eccentric central artery. Okay, so White pulp consists of lymphoid follicle with a germinal center with eccentric central artery. In red pulp consists of splenic cords and splenic sinuses. Here we can see the splenic cords and splenic sinuses, which appear red in color because of presence of the blood cells, that is the RBCs. Okay. Periarteriolar lymphatic sheath, which consists of T lymphocytes. Here in this lymphoid follicle, we have arrangement of various lymphocytes, that is B lymphocytes and T lymphocytes, of which the periarteriolar lymphatic sheath, that is the periarteriolar. Peri means surrounding, arteriolar means surrounding the artery. Periarteriolar lymphatic sheath, that is when there is, here is the artery, it's surrounded by the periarterial lymphatic sheath, which is consist of T lymphocytes and others are consist of B lymphocytes. So this is the histology of spleen in a brief aspect, but there are more. So when you read in the histology textbook, you will come to know about many things. And here I want to mention something special, that is splenic circulation. That is how the blood enters and leaves the spleen. Okay, first the splenic artery enters through the hilum of the spleen. Then it forms trabecular arteries. As we saw that capsule sends trabecula inside. The trabecular arteries, splenic arteries form trabecular arteries that give the central arterioles that we saw here. Here is the central arteriole, right? So from the trabeculae, they give rise to the central arterioles that run through the white pulp. Then after reaching the deeper structures, that is the red pulp, it will divide into peninsular arteries, that is very linear, that is smaller arteries, that is called peninsular arterioles in the red pulp, which continue as ellipsoids, which are the capillaries. Okay, ellipsoids are the capillaries. These arterioles divide into capillaries into the red pulp. So from here there will be two type of circulation, that is open type and closed type. Usually humans have open type of circulation, and animals such as dogs and cats have closed circulation. In open circulation, these ellipsoids, that is these capillaries, open directly into the splenic cords. Okay, so from the splenic cords they enter into the splenic sinuses, and after the splenic sinuses they all converge to form the splenic vein, that is the venous drainage. Okay, so from the artery it is converted to vein as we reach the capillaries. So from the cords goes into sinuses, which is called as open circulation. In closed circulation, these ellipsoids open directly into sinusoids. Okay. So it does not pass through the splenic cords to enter to the sinusoids. This is the difference between open and closed circulation. And from the sinusoids they go on to the venous drainage. Then another most important point, that splenic sinusoids are surrounded by stave cells. That is, these cells are banana shaped cells. They are called as stave cells. Okay, the name of the cells is important. It has some function that during sympathetic stimulation to increase the red blood cell count in blood, these they will constrict, so that on sympathetic stimulation they constrict, which will give more blood supply into the circulation. Okay, since we have seen that the function of the spleen is to store some of the red blood cells within it and can be released at the time whenever needed. Next we move on to the last topic of this session, that is the clinical correlation. We are going to see about palpation of spleen, splenomegaly, splenectomy, rupture of spleen and referred pain, and splenic puncture. First, palpation of spleen. Usually spleen is not palpable. That is, a normal spleen is not palpable. Only when the spleen enlarges we can palpate, but on palpation we can confirm that the spleen is enlarged 2 to 3 times its original size. Okay, so that it becomes palpable. Otherwise it will not be palpable. It is palpated along the left costal margin, that is inferior to the left costal margin. We can palpate the spleen when it is enlarged, and this direction is from left costal margin towards right iliac fossa. That is the direction of the enlargement of spleen. I will show it in a picture. Then splenomegaly. Splenomegaly is the enlargement of the spleen. It usually results in some conditions such as malaria, liver cirrhosis, and chronic myeloid leukemia, 𝗂𝗫𝗂𝗃. Okay, enlarges towards the right iliac fossa, as we saw that, because there will be a 𝗧𝗏𝒃 ligament giving a support on the left inferior aspect, and it is differentiated from the kidney enlargement, because on palpation, since both lie on the left side, it is differentiated from the kidney by the presence of notches present on the superior aspect. So these notches are very important. See here, enlargement of spleen. First, on mild enlargement, it is present along the left costal margin. Then it enlarges towards the direction of the right iliac fossa. Okay, and when the spleen is ruptured, there will be flow of blood from spleen to surrounding tissues, right? So on this flow of blood, the blood irritate the phrenic nerves that is present in the lower part of the diaphragm, that is lower part of left dome of diaphragm. It will be irritated by this blood, so that the pain is referred to that of the phrenic nerve. Phrenic nerve originates from C3 to C5. Okay, so this region is corresponding to the dermatome of C3 to C5, so that there will be referred pain in that area, that is on the left shoulder. This is very important sign, which is called as Kerr sign, K-E-H-R, Kerr sign. Okay, this is very important because it will give an idea about splenic enlargement even in mild cases, whether it's mild enlargement cases. The splenic rupture can be identified with this Kerr sign easily. Then splenectomy. Splenectomy is the surgical removal of the spleen when ruptured. It is also used as a treatment for blood diseases. Also impair function, it does not highly impair function, that is the immune function of this spleen. Okay. Partial splenectomy is done when any segment, only one segment is affected, and we can preserve some splenic tissue for its function. This is done as we already saw that there is a segment of spleen and arteries are segmental in nature, which gives rise to this splenectomy, partial splenectomy. Then rupture of spleen. Even the spleen is located within the 9th to 11th ribs. It is ruptured frequently following a severe abdominal blow. Okay, a severe blow, it can be ruptured even when it is well protected. So I said about the Kerr sign here. So blood from the spleen collects at the dome of diaphragm, causing irritation to the phrenic nerve, causing the left shoulder pain, which is called as Kerr sign. It should be correlated so that findings cannot be missed. Referred pain. It is most important aspect because you will learn in the physiology that visceral pain is not localized easily, that is poorly localized. Okay, so here enlargement of spleen, that is enlargement of spleen usually refer to the epigastric region, and overextension of its capsule gives pain in the left hypochondrial region. Okay, that is, it is poorly localized and can be sometimes clinically correlated. And the splenic puncture. Spleen can be punctured through the 8th or 9th intercostal space when it is enlarged, so that we want any findings such as the intrasplenic pressure and the splenic venography. For this we need to puncture the spleen, that is through the 8th or 9th intercostal space with the lumbar puncture needle. So in this process, to avoid more damage to the spleen, one should hold his breath during this procedure. That is, during this entire procedure of inserting the needle, one should hold his breath so that the damage is minimal. Here intrasplenic pressure is the direct record of portal pressure and hence useful in the assessment of portal hypertension. Also, systemic venography, that is splenic venography, reveals and confirms the enlarged portosystemic communication in case of portal hypertension, which is essential to know about the effects caused by the portal hypertension. Okay, this is the splenic function. So here we saw about the all the aspects of spleen. Please read it in textbooks so that it will be remembered forever. Thank you.